The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to today's webinar on what we hope will be a growing relationship between ACOs and house call providers to both improve care and lower costs. The American Academy of Home Care Physicians is a professional society for the field of home care medicine. Our webinar objectives today are to explain why a focus on cost reduction is critical and why ACOs should consider adding house calls to their plans. We will give some examples of how the relationships can be established, some suggested next steps, and answer questions. We have both ACOs and AAHCP members on this call, and we hope that this will be the beginning, not the ending of the discussion. Our presenters are experts who know the issues and the how-tos. Dr. Rodney Hornbeck is a practicing internist and geriatrician active in home-based primary care. He is the managing partner of Essex Internal Medicine in Essex, Connecticut, an early adopter of EMRs and one of the first practices in Connecticut to win PCMH recognition by NCQA. He has been the leader of clinical integration efforts for medical professional services in IPA, representing more than 400 Connecticut physicians that began operations as a CMS-approved ACO on July 1, 2012. Attorney in health policy Wong Jim Powers, Sutterville, led the Academy's successful fight for inclusion of this kind of programming in the Accountable Care Act. Jim continues to work with the Academy and other associations and also represents both ACOs and home care medicine providers, among other clients. Gary Schwartz and I are both on the Academy staff. Gary, who has an extensive practice management background, will both present and be ready to follow up with technical assistance. I'm a retired hospital and health system CEO whose third career has been to support the growth of the field of home care medicine as Academy Executive Director since 1997. Dr. Teresa Soriano, who leads the home-based primary care programs at New York's Mount Sinai Hospital, another ACO, is not able to be with us today. She has, however, recorded her presentation, and both that and the slides will be on the AHCP website after this webinar. Please note that you can write your questions at any time in the box provided to you on the screen. We will answer as many as possible in the Q&A period. So it's all yours, Rod. First.
Thank you, Connie. If we could have the first slide.
It's not advancing.
Well, let me begin talking. There we go. Next slide. I don't need to tell this audience that the healthcare delivery system is in transition. And if we divide the way we look at this as what's driving that transition and then look at the vehicles, I want to just spend only a moment talking about what I refer to as the quality cost paradox and then shift attention to one of the vehicles, namely accountable care organizations. Next slide. The Dartmouth Atlas has documented amply the amount of variation between the highest cost and the lowest cost medical marketplaces. What isn't as widely understood is that there's a direct and inverse relationship between the efficiency of a delivery system and its quality. That is, the higher the cost, the lower the measured quality that occurs in hospitals in those regions. These are simple measures such as aspirin and beta blockers after myocardial infarction. So efficient markets tend to be also well-performing markets in terms of measured quality. Next slide. This also highlights, this is from the Commonwealth Fund, and this highlights the variation from state to state in 30-day readmissions, and we'll see that there's also a direct linear relationship between cost and readmissions. That's global cost, not just cost of the hospital stay or group of hospital stays associated with the readmission, but all costs for beneficiaries in that state. Next slide. Accountable care organizations were, of course, implemented as a result of the Affordable Care Act. In my area of southern New England, in a fairly less densely populated region halfway between New York and Boston, we have 4 chartered ACOs, 2 more coming online in January, or expected to come online then. And I expect that market penetration by ACOs in our marketplace will be 25% within the first 12 months of operation. Next slide. Our market is also developing all-payer accountable care organizations, and yours may be as well. And as you know, this is a double hurdle system. ACOs must first improve quality, and if and only if that's been achieved are they eligible to share in cost savings. Since there's such a focus on quality improvement and cost savings, ACOs are facing demands for re-engineering how care is delivered. Next slide. In my region, my ACO has taken an evidence-based approach to where we think the cost savings are. There are lots of things that a successful ACO has to do, but we think that by focusing attention on the 10% of seniors that consume 80% of the resources, that the ACO has a better chance of being successful. And we have identified 3 clinical strategies. The first is improvement in care transitions, and that's an ongoing process with hospital partners who also have a vested interest in achieving that goal. The second is not so apparent, which is ready access to primary care at the locations where we find the 10% of seniors that consume 80% of the resources, which we think is largely in the home. And then finally, patient-centered care focused on patient goals, and what we mean by that is clarification of patient goals regarding palliative and hospice care towards the end of life. I should point out that avoiding readmissions, which is the focus of all our hospitals, is necessary but not sufficient for success. Success demands avoidance of the initial hospital stay, not just the readmission. Next slide. Let me spend a minute talking about care transitions, just to say that 65% of all avoidable Medicare costs are paid for hospital and skilled nursing facility care, so that the evidence clearly shows that improving these transitions of care, a la Eric Coldman and Mary Naylor's work, can produce a significant savings. Next. This is the meat of what I want to talk about, which is access to primary care, and I want to highlight the research done at the Veterans Administration through their program of home-based primary care. Next slide. Beginning in 1998 and continuing through to today, the VA has begun administering a program of primary care in the home that involves physicians, advanced practice nurses, traditional home health nurses, and a whole team of people that are listed on this slide and focused on the most frail veterans. This group of veterans has a 24% annual mortality rate, and 48% of them are dependent in 2 or more activities of daily living. So these are the sickest of the sick. Next slide. By 2002, the VA had reported a 24% reduction in total costs of care, with a 63% reduction in hospital costs, an 87% reduction in nursing home costs, and coupled with a 460% cost of providing services in the home. Someone pointed out that since these veterans are free to go to the local community hospital, that perhaps the VA is reducing costs by pushing people back into the Medicare program. But in 2006, the VA reported that there had been an additional cost reduction in the Medicare program of 10.2%. So 24% reduction in VA costs and a 10% reduction in total Medicare costs for this population. The next slide shows the relationship between frailty and cost savings. Across the bottom of the slide is the mean CMS hierarchical condition code. This is the code that determines the premium that is paid by CMS to a Medicare Advantage plan, but is also used to index patients based upon severity of illness. And you can see that as you go from the 1st to the 10th decile of hierarchical condition codes that the observed annual cost and then the annualized post-enrollment cost dramatically increase. In fact, in the lower half, there is no benefit from home-based primary care in reducing costs. It's only in the 5th through 10th decile of patients that you see these dramatic changes. And if you go to the sickest, the top 10 or 20%, you'll see very dramatic reductions in costs. And that ends this portion, and I'll turn it over now to Connie Rowe.
The evidence base for home-based primary care can be found in basically 3 places: the published peer-reviewed journals, reports by leading house call practices, and through the Independence at Home program that we're going to be talking about in a minute, there will be evolving knowledge. This is a 3-year demonstration, and all 3 of these are important to understand. As Rod pointed out, the VA's home-based primary care program is an absolute treasure trove of data about what happens with this intervention to the sickest patients. As he said, there was a 24% overall savings against usual care. We're told by Tom Eads that this is something that they can't do without anymore, and I give the citation to one of the articles about this program. Another one that's been going on for a long time is the GRACE program in Indianapolis, Indiana. It too shows the data in a randomized controlled clinical trial for reduction in ER visits and hospitalization rates. And I give two places that program has been written about. There will be more data coming out. There are others, but those 2 would certainly give any ACO a place to start. The second is reports by leading house call programs. I list 2 here. There are many more on our IAH Now website, which has information about the evidence base for the Independence at Home program. Here are 2, the geriatric specialty care, North Central Nevada, which has been operating for many, many years, and its cost reductions. The Call Doctor Medical Group in San Diego has been operating for 25 years and has cataloged these kinds of 59% numbers and per capita savings numbers. We also have on our website, from our annual meeting, reports by a variety of programs across the country in reducing hospital readmissions. So that readmissions list is also available to you on our website. The third is the evolving Independence at Home demonstration information. Independence at Home, as most of you know, is part of the Accountable Care Act. It targets the highest need, highest cost patients, providing home-based primary care, plus 24/7 comprehensive care coordination, and requires a 5% savings plus meeting quality and patient satisfaction measures. It's a 3-year demo ending in 2015. Well, the AHCP has, with the grant support, an IAH Learning Collaborative, so that the 15 sites and 3 consortiums all together are talking about the evolving best practices, the problems in operating these programs, and the information from that will be published by the Academy as part of its ongoing educational effort to report on the IH demonstration and the learning that is being made internally even before the formal CMS evaluation at the end of the demonstration, which, as most of you know, can be up to a year after the end of a demonstration and sometimes even longer than that. So these are 3 places to start for those of you who are interested in ACOs in looking at the evidence. Also, those of you who are members who are interested in developing proposals for ACOs are welcome to use any of this information as you develop proposals. Now I will turn it over to Rod again. Rod?
Thank you, Connie. Connie asked me to speak a little bit about my own practice as I introduce this section. I'm an internist and geriatrician in a small practice with 3 physicians, part of a 250 doctor single tax ID group. But our site is a small one in a relatively unpopulated area for the Northeast at least. And I've been making home visits in that context for a long time. I make about 400 home visits a year, and that's about 10% of my total practice. I do it by limiting access to home visits to the contiguous zip codes around the practice, making the commute from the office to the home easier. We have retooled our practice. We are now a level 3 patient-centered medical home, and I'll talk a little bit more about how that impacts patient care. And we've redesigned the role of traditional home care in our community as well. So then I want to talk a little bit about thinking about how to pay for home-based primary care in an ACO environment. So if I could have the next slide, please. There are 3 kinds of physicians involved in home care, or home visits, I should say, and that's a group of people that only make home care, home visits. They do not have an office-based practice or a hospital-based practice, but only make home visits. And they tend to be, although not exclusively, in urban areas. The second is those who have a office-based practice and make home visits as part of the practice, and that's the way that I practice medicine. And then there are those who haven't yet made their first home visit. I would also point out that adding advanced practice nurses with experience or interested in geriatric care can be extremely important to making the program a success. Next slide. So how do we redesign care, or how did we redesign care? We think that regularly scheduled visits work best. In fact, home visits for urgent or especially emergent problems don't work very well at all. You still have to have an emergency room for people who are acutely ill. But for high-frequency, low-intensity visits are especially effective. So a typical patient in home care or home visit practice will be seen on a monthly or every 2-month basis. And if you have a nurse practitioner, you might increase that so that the nurse practitioner sees the patient in between visits by the physician. Those visits are targeted on frequent flyers, those who are in and out of the hospital, who are most frail and most vulnerable. They're supplemented by telephone contact, and there's a focus on hotspots. My medical assistants in my office know all the patients who we see at home and are able to alert me to the fact that there may be a problem that can be addressed quickly at home, but which, if ignored, will cause problems. And a good example of that is the patient with congestive heart failure who's gaining weight, or the patient who is with dementia who is suddenly confused, and where one of the first steps would be to check for a urinary tract infection. We use telemonitoring in the context of the traditional Medicare home care benefit very selectively. This is not one size fits all, but for some patients it's extremely helpful. And then we've learned to maximize the value of traditional home care. Next slide, please. Although Medicare home care is rule-bound and financially constrained, it can still be valuable with minor modifications in the relationship with home-based primary care physicians. In my community, we brought together a group of home care agencies and a group of physicians, and we very quickly, in fact less than an hour, we identified a number of barriers and implemented a number of changes in the relationship between physicians making home visits and home care agencies. The first was to enhance the flow of information. I must say that in my community we are blessed by having a hospital that produces a discharge summary that arrives at my office on the day of discharge. I understand that's rare. We've simply expanded that so that the nursing agency gets the home health agency gets the same information. That's flattering to the nurses. They're not getting just a handwritten summary of meds and last treatments that they are used to getting, and we find that they're working at the top of their license as a result of this newfound respect. The second thing was to exchange names. Many physicians have no idea who the nurse is on the other end of the line. First and last name and cell phone numbers were exchanged. The nurses in my community visiting my patients call me directly on my cell phone, and I can return a call directly to their cell phone or institute a call, for example, those hotspot patients that need to be quickly assessed. And then finally, the home care agencies have retooled their on-call system. Previously, some of the home care agencies would simply answer the phone at night, listen for a while, and say, I guess you better go to the emergency room, which of course is anathema to a practice who's trying to avoid just that. While it doesn't deal directly with the process of reengineering, there's a report from a statewide effort in Ohio that's referenced at the bottom of the slide that shows what redesigning home care services can do for readmission rates. And I direct your attention there. Next slide, please. I think it's important to understand that financial models are important, and some of those are just emerging based on the ability of a home-based primary care team's ability to manage a portfolio of patients who are the ACO's most costly, and Gary Schwartz will discuss that in more detail. And yet, ACOs are bound by the traditional fee-for-service system on which the model rests, which means that the only new money in the system is from the sum of shared savings minus startup and operating costs of the ACO, and so they're tenuous at best. The only exception to that is the advanced payment model ACOs, and unfortunately in our community I'm operating in an advanced payment model ACO. Next slide. It's important for ACOs to recognize, particularly in markets where Medicare Advantage plans have a large portion of the market share. Medicare Advantage plans are already busy leveraging home-based primary care practices to reduce overall costs, in some cases quite spectacularly. So you have to compete for those doctors' attention with the Medicare Advantage plans. I would also point out that shared savings ought to be weighted to account for the HCC mix of the home-based primary care teams, and to, of course, measure it against the performance of the team in reducing cost and improving quality. Financial performance measures for these small numbers of patients, even though they generate large costs, you still have the statistical rules that apply, and so outliers need to be removed from the calculations. And ACOs that are receiving advance payments ought to really consider investing in home-based primary care capacity. And with that, I'll turn it over to Gary Schwartz.
Gary?
Thank you, Rod. This section of the webinar is to discuss how you would identify the home-based primary care population for your ACO intervention, a method to calculate savings that could be achieved, and then describe options for developing the home-based primary care practice for your ACO. Next slide, please. First, you want to screen for the highest cost patients that would benefit from your home-based primary care. Dr. Hornbeck and others have described this cohort as the frequent flyers and as hotspotting. You can obtain data from your systems through age and cost screens. An age screen of 75 years old, for example, could be used initially, and as Dr. Soriano's presentation that will be posted on the Academy site provides, this age screen may ultimately reflect 75% of your home-based primary care population. Also use a cost screen and establish the 5 to 10% of the patient population that explain the disproportionate share of cost. You can screen for charges, payments received, or claims paid depending on your entity. Since ACOs are collaborative, you will want to share your list with the other entities in your ACO to see if the patients match to them as well. These screens, with some further analysis, should produce your initial targeted home-based primary care population or portfolio, as Dr. Hornbeck also described. Next slide, please. This slide reflects the further analysis you will want to conduct. For example, in reviewing the reports that are generated based on age and cost, drilling down into the reports and the medical records as necessary, which patients are those for whom ER visits, admissions, and SNF stays have replaced the medical office and clinical visit? Which patients have not been seen in the office within a certain time frame and could be followed into their residence? Which patients lack social support network, as this has been found to be a key determinant of admissions? Which patients reflect 2 or more of the costly chronic conditions, COPD, heart disease, diabetes, and as Dr. Hornbeck mentioned, congestive heart failure? Which patients are those for whom the limitations of activities of daily living exacerbate the chronic medical conditions? Which patients are home limited? And this is Medicare definition is not that of the Part A homebound. And then finally, the patient HCC score. Do you know that? Is that able to be established, and is that above that for your office patient? Next slide, please. What this slide reflects is, turns to is what a home-based primary care budget would look like. Your initial ACO methodology is based, as you know, on the HCC risk adjustment methodology of Medicare Advantage plans and other CMS programs. And this slide walks through the budgeting or expected expenditure for one patient and then extrapolates to a population or portfolio to be managed of 50 patients. For one patient, we use a typical CMS Part A and Part B expenditure in fee-for-service Medicare of $900 a month. We then multiply this by an HCC score found in home-based primary care patients of 3.7, and Dr. Hornbeck showed on the slides from the VA home-based primary care that range of HCC scores. And using a score of 3.7, this produces a expected monthly cost of the $3,333, and then we multiply this by 12 months to produce the $40,000 expected expenditure on an annual basis, and thus 50 of these patients would produce a budget or expected expenditure of $2 million. Next slide, please. Here on this slide, we see that based on the evidence discussed earlier and also to follow, what savings could be expected. And this slide reflects a range of savings across the top and the dollars that would be achieved. For example, using the VA home-based primary care experience and that range of 13 to 24% savings, and even using a low figure of 15% to reflect the savings produced, we see that on the budget of $2 million, that would reflect a savings of $300,000. Moving to the right, Hospital at Home and Elder Pack have produced even greater savings, and that's indicated under the 30% column, producing projected savings of $600,000 from the target population. And Inspirus, operating in a private health plan environment, has produced even higher savings. Thus, seeing the strong benefits of the home-based primary care model and intervention for your ACO, we want to turn to how to add home-based primary care capacity to your HCO. Next slide, please. This slide presents the options to add home-based primary care capacity to your ACO on the left side and reflects the range of control that is typically reflected by the options on the right-hand side. So to develop the home-based primary care capacity, you could establish referral arrangements, obtaining service through referral relationship with existing house call programs in your community on a non-contractual basis. You could have a contractual relationship with no risk sharing, obtain service through a contractual medical coverage relationship that may or may not touch your ACO risk or gain share. You could establish a contractual relationship with risk sharing and obtain service through contractual medical coverage relationship that is formally tied into your ACO organization. And then moving into stronger models and forms of control to produce savings, you could diversify by adding physicians, nurse practitioners, and PAs to provide house calls through one or more operating units of your ACO. And while doing that, you would also have the Medicare Part B coverage and payment for revenue for services rendered. And then finally, to the strongest model, you could develop house call capacity within existing primary care practices in your ACO. You could use existing or add physicians, nurse practitioners, or PAs to provide house calls. And again, you'll have the Medicare Part B coverage and payment for revenue. ACO representatives on the call will want to review their organizations for how to develop this capacity, and Constance Rao will describe how the Academy can help. Additionally, Academy members on the call will want to customize the information on these slides for presentations as to the value of home-based primary care and their practice specifically to the ACOs in their practice catchment area. Academy members will also want to review and incorporate information from the policy brief on readmission avoidance and care transitions that is available on the Academy site. Again, Constance Rao and I can help you to develop a presentation based on the specifics of your practice and community.